This patient presented to us with retention of urine. Patient was catheterized for the past 3 months. He had history of thinning of stream for the past 2 years and nocturia for the same period. He had previously shown to another surgeon who had taken multiple prostatic biopsies for the raised PSA levels to rule out prostatic carcinoma. Here we are entering the urethra, and that is the bulbar urethra. It's the membranous urethra now, and we have reached that's the verumontanum and the prostatic urethra. That's the prostate. That's the bladder neck, and we are entering into the bladder. This is showing the trigone and the ureteric openings. Both appears normal. There it's the left ureteric opening. Now we start with the TURP. We start at the bladder neck, the median lobe first. I am using the monopolar cautery for doing the TURP. We use glycine for doing the TURP procedures. Now this patient had multiple abscesses due to the previous biopsies taken for raised PSA to rule out prostatic carcinomas. Since the patient had received multiple doses of antibiotics, these prostatic abscesses were organized partly. Now here we have opened up one prostatic abscess. This is the pus that is coming out, organized partially. So what we do is that we de-roof the prostatic abscess and drain the cavity. That's the universal principle of drainage of a abscess. Since these are multiple abscesses and the prostate, it was not advisable to go through the transrectal route to drain them. So we decided to do the TURP and the drainage of prostatic abscess in the same sitting, since that was the only viable option for the partially organized. Here you can see the pus coming almost like a serpentine excretions from the prostatic gland. There's slight bleeding. We will cautery that. There, more we open up, more prostatic abscesses start straining, and these are small abscesses which are partially organized because of the large doses of antibiotics the patient has received from the previous surgeon. So what we are doing is that we are de-roofing the prostatic abscess cavity and draining out as much pus as possible. That's a small coagulation here. Now this cavity again we have opened up, still draining. These abscesses are best drained if they are small through the trans-uretheral route. If they are large, they can be drained through the transrectal route. The radiologist had given us a hint from the transrectal ultrasound, which given the report as multiple prostatic abscesses which partially organized, and the prostatic volume was 45 ml approximately. The patient was given an antibiotic cover, and when the urine culture came as negative, we decided to go ahead with the surgery. There we almost reached the capsule. The abscesses are drained. The cavity, now you can see the cavity has been opened up. Still the abscess from the other side of the abscess is opened up. That's verumontanum. We've almost finished the resection of median lobe. Now we'll start with the resection of the right prostatic lobe. Here we started with, and we'll continue the resection till we reach the capsule. One must be careful not to go beyond the capsule, as torrential hemorrhage can occur if we go beyond that. So that decision one has to take, how deep one goes for draining the abscess. uh, that has to be taken on table. There, we have almost completed the right lobe and the median lobe. Now we go in for the left lobe of the uh, adenoma. There is a small abscess also in the left lobe that will be drained with the resection of the left lobe. This was an interesting case, so I decided to put it on the tube for people. Now this is going in for the left lobe of prostatic adenoma. We go ahead with the resection till the capsule is reached some hemostasis. I go ahead right in the coagulation, as when a large vessel is exposed. Otherwise, if we leave it for the end of the surgery, that can give rise to a lot of hemorrhage and reduced vision. We have almost completed the resection of prostatic adenoma. Here we can see, now that is the zero flow. We have stopped the flow, and I want to see if there is much bleeding. There are still small abscesses which are left, and still they are coming out. So we will yeah, there, we'll uh, open up these cavities as well. So that's what we are doing, and we've almost completed with the resection. We've reached till the capsule. This white glistening fibers are of the prostatic capsule. The adenoma is almost resected. The patient will be started on a broad spectrum antibiotic and continued with that because it's always on antibiotic. There we have completed the resection. It's a good adequate passage that has been created after the resection. The bladder wall is okay. Thank you everyone.